Good morning here and good afternoon or good evening in India. It's always a great pleasure to talk to anesthesiologists in India and exchange ideas. As I teach, I learn too. And I thank the organizers of the Kerala ISA for having me invite to present this topic. Today, I'm going to highlight on the management of peripartum hemorrhage. I will actually touch upon some practical aspects of this management so that it will be useful as a clinician in the management of obstetric hemorrhage. I do have disclosures to make. I do maintain a website on capnography, which is free for all. And I also maintain a painfreebirthing.com website for the patients to explain what are the modalities we have for labor analgesia during their upcoming delivery. Now, Taj Mahal, although a symbol of love, is a tragic reminder of postpartum hemorrhage. It is said this princess actually died of postpartum hemorrhage. Now, as recently, say about 30 years ago, Smita Patel, one of the outstanding film actresses of Hollywood, also had a postpartum complication and died. What I intend to say from this is for centuries, we have been trying to tackle the management of peripartum complications, particularly the obstetric hemorrhage, and we have some success, but not completely mastered the management. Now, when you look at the physiology of pregnancy, particularly the cardiovascular changes have an important bearing on the management of postpartum or peripartum hemorrhage. The cardiac output increases from 5 to 7.5 liters, and if someone is obese, it may go up to 10 liters. And if the cardiac output of a patient is 6 liters because of hemorrhage, then it is an abnormal number, and that must be remembered. Because the cardiac output is high and the blood volume is also high, which increases by 40%. These two, together with the hypercoagulation of pregnancy, offer some resistance to blood loss. What I mean to say is a pregnant patient can tolerate some amount of blood loss because of their high blood volume, and as well as because the TEG is, or the thromboelastogram, or the blood is hypercoagulable, they are able to clot early. So they do have some safety. However, when the blood loss occurs, they do exhibit signs, and particularly when you look at the class 3 hemorrhage or class 3 classification, where when the blood loss is about 30 to 35%, it is approximately over 2 liters, the heart rate goes up to 120 to 160, and the extremities are cold. And if someone has hypotension because of hemorrhage, you can expect that the patient has already lost about 30 to 40% of the blood volume. And remember that it is the 30 to 40% of the blood volume which is already increased. So it is a substantial blood loss has occurred. Now, one of the problems with the peripartum hemorrhage is it just occurs rapidly and it is unanticipated. Even now, I always prefer to do a complex obstetric cases under elective circumstances than doing a regular cesarean section in the middle of the night, because I don't know if this patient is going to bleed or not. I mean, most of the times everything, proceeds fine, but an hemorrhage can occur anytime, and particularly in the middle of the night when the staffing is decreased or sparse. So what do you do when there is a peripartum hemorrhage? The first thing is pray whomever you want to. Why? Because access to safe blood actually reduces maternal deaths. But in India, as we all know, that there is a problem to get blood in abundance quality and immediately available, particularly to a smaller hospitals. I'm not talking about big institutions that are very well equipped. And as I already said, the hemorrhage is unanticipated. And the second thing is the maternal mortality from postpartum hemorrhage or peripartum hemorrhage is about 30% of all deaths, of maternal deaths, particularly in India. And this is true in majority of the countries. So anyone who is practicing obstetrics or anyone who is taking care of pregnant women in their hospital, irrespective of the size of the hospital, must have a maternal safety bundle for obstetric hemorrhage. It is published in many journals, that are available, and it actually lists 4 important R's actually. One is readiness, means we have to have some planning, some checklists whenever an hemorrhage occurs, like an hemorrhage cart with all the equipment that is needed, headband, saline, whatever it is. Second thing is recognition. There are certain times when you think that a particular patient is a very high risk of hemorrhage and you do not have resources at your hospital. It is probably prudent to transfer this to a bigger hospital which may have much better facilities to tackle this case in the event of their problem. So you can recognize certain cases much earlier. And another thing is you can also recognize that some patients are more prone because of their diagnosis, and therefore you can be prepared. Third is a response. There is some sort of a standard approach in the management of peripartum hemorrhage, and this should be known to everyone in the group taking care of the obstetric patients. And the last one is, of course, reporting, and system learning. That means we learn from our approach, from our past, and try to improvise upon that. Remember that peripartum hemorrhage management is a teamwork. It must involve not only the obstetricians and anesthesiologists, but the ancillary staff, the nurses, the OR personnel, the laboratories, personnel, and also the blood bank personnel. So it is not just between obstetricians and anesthesiologists, but it is a conglomerate of all these groups that are essential in the final success in the management of the peripartum hemorrhage. So what to do when there is a hemorrhage? Assess the situation, call for help. This is very important step of management because you need help to put IV lines, to pump blood, to send labs. Communicate with obstetricians. What is their thought process? What is their, what is their plan? How they are planning to control the hemorrhage? And then look for, of course, IV accesses. Mobilize resources for transfusion. That means someone has to call blood bank and obtain blood. And then if the hemorrhage occurs in the labor and delivery rooms, the patient must be transported right away into the operating room. Now, a massive blood loss requires massive transfusion, and massive transfusion requires massive transfusion protocols. Now, what is massive transfusion? There are several definitions of massive transfusion, but if 50% of the blood volume is replaced in 3 hours, or a loss of more than 50% of blood volume in 3 hours and requires transfusion, you may call it as a massive transfusion. Now, if you don't have massive transfusion, what happens? You say that I need blood, they'll say they need type and cross, and then they release emergency blood. Then, okay, you tell the nurse will call the blood bank will send the blood, then you need FFP. Again, the same process repeats. The advantage of having a massive transfusion protocol is it is rapid and timely delivery of large amount of blood products can happen quickly because it is already the plan is pre-arranged. For a patient with unknown blood type, you get either O negative or O positive RBCs with AB group FFP. For patient with known blood type, of course, we know what to do. Predetermined mix of RBCs, FFP, and platelets will arrive into the operating room. They reduce the time and also the number of personnel required and effort required to obtain blood products because it is already a pre-planned process. In our setup, we have a telephone number and we call and we activate, and immediately you get O negative 6 units of blood, followed by plasma 2, and then they put another 4. They also send a bag of platelets initially, and this process continues until you tell them, say that we are good. I said, this is possible in an institution of a high-level care, but a prototype of this can be established in any smaller hospitals to cater to an unanticipated obstetric hemorrhage. Now, as I said, in pregnancy, there is increase in blood volume, cardiac output, and there's a relative anemia. One must refrain from giving too much of fluids because although pregnant patients have some resistance to coagulopathy, when you give fluids because of high von Willebrand's factors, factor VIII in fibrinogen, but it also activates the fibrinolytic mechanism. And of course, it also produces dilutional coagulopathy. But if we do not have facilities for blood, then of course we have to take the less ideal approach, which is given fluid, stabilize the patient, and send it to a bigger hospital, or plan out what is the further mode of action. That means you may get blood if you wait for a little time. Then the third important thing you have to remember is the Starling's equation. The Starling's equation is always towards pulmonary edema in pregnancy. Now, normally, the oncotic pressure is about 24 in non-pregnant patients. In pregnancy, it could decrease up to 19. And if someone has got preeclampsia, it can go down to 17. And when you give fluids, you give more fluids, what happens is the fluid simply transsudates into the interstitial space, thereby producing subclinical or pulmonary edema. And this is an important thing. That's why giving too much of fluids, there is a problem. But you have to do sometimes to tide over the crisis. Now, this is an example where, as you can see here, if you look at the end-tidal CO2, it almost went up to 70s and to almost 83 with the respiratory acidosis. And this is because, although it was thought that this patient might have developed folly, but it is more likely to be fluid overload, giving too much of fluid in a very short time. And this can also lead to sometimes, interstitial pulmonary edema and difficulty in ventilation. Then, of course, HESPAN. HESPAN is a reasonable choice to tide over the crisis as long as it is limited to 500 ml because it does interfere with coagulation. And again, as I said, if you have to use more to tide over the crisis, I think it is the second best option you have. Now, what happens to fibrinogen during obstetric hemorrhage? And this is one of the key elements I want to emphasize on. In obstetric hemorrhage, the fibrinogen actually takes a dive. And when the fibrinogen level goes below 200 milligrams, it has a positive predictive value to progress to a severe hemorrhage. And that is why we have to track fibrinogen level and maintain it at least around 200 in order to prevent ongoing bleed. Now, When there is an ongoing hemorrhage, one factor that always comes to our mind, can we prevent coagulopathy? Is that a better strategy? I think if you are able to prevent coagulopathy, is always a better strategy. The reason is very simple. If the blood is clotting and the bleeding is continuing, then it is a surgical bleeding, because majority of the time the obstetricians will always say it is coagulopathy and it is not surgical. And therefore, if there is no coagulopathy, at least they can concentrate on fixing the problem rather than thinking that it is a coagulopathy. Now, how do we know whether the coagulation is normal? Well, there are conventional labs like PT, PTTI, NAR, fibrinogen, etc., CBC for platelets. And there are more sophisticated like TEG, Rotem, and hemosonics. But all of them take time. There is a lag. So how do we assess coagulation quickly, right away? And of course, we are one of the fortunate in United States to have both TEG and Rotem. And we recently also used another point of the care coagulation analyzer from Quantra. It's called as a Contra System Analyzer. And we recently published this paper in the Journal of Clinical Monitoring and Computing, where we did a serial dilutional study of fibrinogen. We decreased the fibrinogen down to almost 150 and then evaluated how this system works. And it works very reliably, actually. And you get the results in about 13 minutes. And it is a cartridge based. You take the blood sample, the blue top, and put it in, press the button, and you continue management with the patient, and you get the values in 13 minutes. So it's a very user-friendly point of the care system. Despite all this, I still do this. I take blood in a red top and then wait for about 10 minutes and see if the clot forms. And I try to actually sometimes, because as I said, we have TEG and Rotem, I try to correlate this, just as an interest, not as a study, just as an interest. And whenever the blood clotted, the TEG or the Rotem was normal. And I was delighted that this paper actually came from Raipur in India, where they evaluated this point of the care blood test, in a red top to the conventional fibrinogen, and they found a fairly good correlation, I should say. And what they also found is if the clotting time is between 7 and 11 minutes, the fibrinogen is about 332. And if it is greater than 11 minutes, it is about 158. Before I saw this publication, I normally use 10 minutes. If it is greater than 10 minutes, I'm concerned that, there is probably a coagulopathy that may be occurring in this patient. So it gives me some idea. If the blood is not clotting, I don't need any other labs. I start the blood products right away and then check the labs. Now, if the blood is clotting, then I look at the labs to see where am I? Am I very close? Is the fibrinogen is getting too close to 200 or it is fairly above? These are the two highlights of this study. Now, how do you prevent coagulopathy, or how do you manage, to prevent coagulopathy? Now, as I said, you can do whatever tests that are available. And I also do what is called as a poor man's tag. If it is abnormal, I right away transfuse with the products. If it is normal, then I try to prevent coagulopathy. And of course, when the blood loss is more than a liter, you all know the tranexamic acid is one of the standard approaches now, if there's no contraindication. Now, how to prevent coagulopathy? That means how much of blood loss can actually derange the fibrinogen level or decrease the fibrinogen level to 200. It's very difficult to answer that question. But there is a study, and of course, when you are actually looking at the blood loss, you have to know how to estimate it. For example, how to estimate the blood loss. One is the visual estimation is best. Then there are some quantitative estimations by weight. That means the nurses weighs and they come up to the, you know, uh, uh, say that this is the blood loss by weight method. If you are going to use these two methods, I think it is a reasonably good approach. And as I said, if your blood loss is more than certain value, the fibrinogen can be derived. But what is that blood loss? Probably the answer to this question is from this paper, which is a study done in the Europe. What they found is if the blood loss approaches around 2.5 liters or so, then the fibrinogen is likely to come down to 200. Now, I tried this in some patients. Here the blood loss was 200, but look at the fibrinogen, it is 173. And here the blood loss is about 1.5 liters, and the fibrinogen was pretty good. The reason why there will be a disparity using this, the 2.5 liters, 3 liters is we do not know what is the pre-existing fibrinogen in a given patient, because the pre-existing fibrinogen in a given pregnant patient could be anywhere from 200 to 600. So if a patient has a high fibrinogen, then their margin of safety is much higher, whereas compared to a patient who has a low fibrinogen, where they have less margin of safety. This is just to give you another technology that has recently come up, estimation of blood loss using the camera of the iPads, etc. It's a very sophisticated device and also expensive. And I did write actually in a small correspondence in anesthesia analgesia saying that for practical purposes, if you use two methods, the visual method as well as the weighing method, there are two good approaches which everyone should use. And if there are two methods are close to each other, you're fine. If the two methods are giving you two different values, then it tells us that, well, we have to be careful here, look at the labs, and then determine further management of this patient. Now, another important thing is when you are in the coagulation management strategy is, nowadays, as you know, that we have K-centra, which is a prothrombin complex that acts here at this step, thrombin fibrinogen to fibrin. And then we have recombinant factor 7A, which actually acts at this level, 9 to 9A, 10 to 10A, and then prothrombin to thrombin. But one critical point everyone must remember is the fibrinogen here. If the fibrinogen of the patient is low, there is no point in giving recombinant 7A or K-centra. We are simply wasting money and resources because ultimately it is the fibrinogen that is important to form the fibrin, along with, of course, platelets. Now, we did a study a long time ago to look at in vitro assessment of 1:1:1, the blood transfusion strategy versus the conventional 3:1. We found that both are good as long as the platelet numbers are high. That means if the platelet number is low, at least in this study it was below 100,000, then 1:1:1 is not that effective. So although we say that platelets are good for 50,000, maybe when there is an ongoing hemorrhage, it is reasonable to maintain higher number of platelets. Then, of course, there is a triad of death. You're all familiar with. One is hypothermia acidosis coagulopathy, and it forms a vicious cycle. Hypothermia and acidosis produces coagulopathy. Coagulopathy produces ongoing bleeding, which further produces acidosis and hypothermia. So, therefore, you have to take precautions to correct acidosis and warm the patients. And I also say sometimes the cord of death, and I put calcium because calcium is one of the key components of coagulation, as you all know, and therefore we have to give calcium or monitor calcium levels. Then the important factor in the management of peripartum hemorrhage is monitoring. You must have arterial line if needed, adequate IV access. If there is an arterial line, we can also measure cardiac output. And I generally tend to monitor stroke volume of the patient. And sometimes I also use some non-invasive methods now, that uses impedance technology and electrical impedance changes during systole and diastole. And they give a reasonable idea about cardiac output in a patient. At least they are good trends. Then, as I said, temperature has to be maintained. Then end-tidal CO2 monitoring is very important under general anesthesia because it actually gives you an idea of cardiac output. If the end-tidal CO2 is below 20, you know that the cardiac output of the patient is below 2 liters. Then frequent labs are essential, and of course, EKG monitoring, particularly for hyperkalemia. Then backup personnel. This is one of the important strategies of peripartum management. You have to know your backups. Anesthesiologists should know when they are in trouble, who is going to help them out. You must have adequate nurses. There has to be a nursing coordinator to look at how the labs are progressing, how the blood is coming to the OR. And we generally have a resource nurse who actually takes the role and coordinates this process. And the obstetricians should also have backup who are capable of putting, either Bakri balloon or, using B-link sutures like this or the uterine artery ligations, because ultimately they have to control the bleeding because the uterus, in a torrential obstetric peripartum hemorrhage, because of the high uterine blood flow of 750 ml per minute, within few minutes we can lose substantial blood. So the obstetricians must also be aware what are the surgical techniques that are available to control bleeding. Then, of course, everyone must remember aortic compression. It is something that is very, very useful. That means you actually press the aorta against the spine of the patient and then obstruct the aortic flow until the uterine hemorrhage is under control. And this is a technique actually that is very, very useful. And I know there's one group in Hyderabad actually using this technique routinely for placenta accreta spectrum cases. So how do I conclude? First thing is, don't panic. Start communication right away. Have a protocol for obstetric hemorrhage. I told you about obstetric bundle. Initiate the protocol, and mobilization of help is critical for success. That means you cannot manage these cases as individual. You have to have some teamwork, for the getting a successful result. Then think of transport to a different institution, because there are limitations what can be done at a smaller hospital or a smaller institution. Therefore, some steps have to be initiated to transport this patient after achieving initial stabilization. Thank you. And I think I will be available live to answer your questions after presentation of this lecture. Thank you very much and see you later.